While we're waiting, just feel free to introduce yourself on the chat stream. Just state who you are, which organization, which duty station you're from. But thank you so much for joining us. This is a DHMOSH Public Health Conversation Series talk. My name is Dr. Esther Tan, and I am the head of the Public Health section of DHMOSH. DHMOSH stands for Division of Healthcare Management and Occupational Safety and Health. It used to be called Medical Services Division, but we changed our name. And we are based in the United Nations headquarters in New York. Today, we have the privilege of hosting Dr. Daniel Lucey for this presentation. And I really want to thank all of you for taking the time out to join us today. If you have not checked out our website to look at the various public health programs that we have, we're going to put it on the chat stream so that you can see. And we've got kind of various health promotion activities and various guidelines that we have produced. That's all on this website. Also, if you're interested to join us for future webinars, you can sign up at a link that we're going to post at the website on our chat stream as well. So a few admin notes before we start out. All attendee lines have been muted. So if you have any questions at all during the webinar, please submit them in the chat box, and then we'll save the last 10 to 15 minutes to go over any questions and discuss them. Please note that this webinar is recorded as well, and a link to the recording will be sent out to all participants after this talk. So with that, it is my great pleasure to introduce to you our presenter for today. He is Dr. Daniel Lucey. And Dr. Daniel Lucey is an infectious disease and public health physician who teaches about epidemics in the United States and other countries. And he's now the clinical professor of medicine at the Geisel School of Medicine at Dartmouth in the US. He has worked overseas during many epidemics, for example, SARS in Toronto and China in 2003, the H5N1 in Egypt in 2006 to 2012, Indonesia in 2008 with MERS, in Qatar and UAE in 2013, with Ebola in Freetown and Monrovia in 2014, Zika in Brazil, yellow fever in Kinshasa, plague in Madagascar with the WHO, and then COVID in China and Egypt 2020. So he is really someone who is real expert in this field and the perfect person to talk to us about this topic. And so we're going to be discussing today COVID-19, a global update in year 4 of the pandemic. Currently, Dr. Daniel also works on COVID and emerging diseases as a fellow at the Infectious Disease Society of America. And since 2020, he has been giving webinar discussions with us at the UN on SARS, on COVID, and other infectious disease topics. So without further ado, let me bring Dr. Lucey on board. And the way we're going to do this is he will present for the first 15 minutes, and then he and I will have a discussion about the topic. And then after that, we will go on to take a look and see if there are any questions that are popping up on the chat that we can discuss even more. So over to you, Dr. Lucey, and thank you so much for being with us.
There we go. Thank you so much for this wonderful opportunity to be with you again, Dr. Tan and colleagues around the world. And thank you for taking the time, everyone, to join in from your busy schedules wherever you are around the world. So I have just a few slides, and I'm going to go ahead and share screen and start with the slides. There they are. Okay, so what I'd like to do here before Dr. Tan and I have the conversation and we take your questions from the chat box is just to provide a few links online for topics that we'll discuss. Dr. Tan and I in the next 30 minutes or so. There we go. So I just want to emphasize that these views and opinions in these slides, and then also in the conversation with Dr. Tan are strictly my own opinions, and they do not necessarily reflect any of
the fuck is the settings, yeah?
Or academic centers, the museums like the Smithsonian, or professional medical organizations like the Infectious Disease Society of America. They're just my own opinions. So the first topic that I'd like to emphasize to you is, I think, perhaps the most important, and that is the issue of trust and pandemic preparedness, and trust in communication. And I was very happy to hear just last month in January that the World Health Organization or Organisation Mondiale Santé, OMS, in Geneva, led by a senior physician, Dr. Sylvie Briand in Geneva, started this monthly webinar series, which the first one in January was focusing on trust and pandemic preparedness. Each month there's a webinar, and the link to the webinar is here at the bottom of this slide. There's also recordings of the webinars, for example, January, then February, there's one coming up March 15th, and all of them focus on the central, very important theme, as I'm sure everyone agree, of trust. So this is a quote from the opening webinar series. It states that the COVID-19 pandemic highlighted trust as an important determinant of successful pandemic response and leadership, a prerequisite for the uptake of interventions and behavior change among communities, and a contributing factor in community resilience. So I highly recommend this series to you in this link at the bottom of the slide. With regard to updates, now as we enter year 4 of the COVID-19 pandemic, what I find are most timely and complete and helpful are these WHO COVID-19 weekly epidemiologic updates. The most recent one was February 22nd, last week. They come out on usually by Wednesday each week, sometimes on Tuesdays. And the link to these weekly epidemiological updates on COVID is at the bottom of this slide, on a WHO website, of course. And just to stand back for a moment and take in the gravity of this pandemic in terms of the number of people, or so we say cases. Last week's report stated that there have been well over 757 million laboratory confirmed persons cases with SARS coronavirus 2 infection, and over 6.8 million deaths that have been reported globally. So obviously these numbers are underreporting because not everyone has a laboratory test for SARS coronavirus 2. So really a very humbling, very severe pandemic. And this is a table from last week's report, epidemiological update. And I would just call your attention to 3 columns. On the far left is the WHO region, from Western Pacific to Americas, Europe, Africa, Eastern Mediterranean, Southeast Asia, the 6 WHO regions. And then the 2 columns in gray in the middle is cumulative cases and the percent of all cases of SARS coronavirus 2 in that region throughout the pandemic. And then on the far right, the last column in gray also is very important, obviously, and that's the cumulative number of deaths in each of the 6 WHO regions and the percent that deaths in each of those regions represents overall worldwide. So just to take an example, if we look at Africa in the middle of the table, and then go over and you see cumulative cases, it's approximately 9,494,000, which represents only 1% of the total 757 million cases. And then in terms of deaths, for the Africa region of WHO, there's been about 175,000 reported deaths, which represent 3% of the 6.8 million deaths worldwide. And you can see some other regions such as the Western Pacific, where there's been just over 200 million cases, which represents 27% of total cases reported in the world. And for Western Pacific, just over 403,000 deaths, which represents only, which represents 6% of the total deaths. The largest number of deaths reported have been from the Americas, 43% of all global deaths. The largest number of cases reported is from Europe, which is 36% of all of the 757 million cases. So again, this is an excellent resource that comes out every week from WHO. As I'm sure most everyone knows, since the past 14 months, a year and about 2 months or 3 months, the dominant variant of the virus in the world has been and continues to be the Omicron variant of concern. And it has many, many what are called descendants, if you will, or sublineages is more of the medical term, but they're all related to Omicron. And again, as of last week's WHO update, 19th February, the data from around the world shows that 99.7% of all SARS-CoV-2 viruses that have been sequenced and submitted to the global public database are Omicron or of some sublineage. As you know, there's multiple different numbers like Omicron 1, 2, 3, 4, 5, and then other designations and terms for Omicron now, like XB 1.5, BF7, et cetera. But those are all related and descendants of the Omicron virus that was first found right in November and December of 2 years ago, of 2021. Fortunately, there's been no new variant of concern like Omicron, or before that Delta or Alpha, or the original virus that was found in late 2019. There's been no new variant of concern. In other words, one that's more transmissible or potentially more dangerous or deadly. But no new variant of concern has appeared anywhere in the world, including in China, since the Omicron variant in late 2021. Unfortunately, the mutations, of which there are many in the Omicron virus and its descendant Omicron sublineages, have caused essentially all of our monoclonal antibody treatments to lose their efficacy. Some of these monoclonal antibodies were especially helpful to people who have weakened immune system, either because of the age or because of cancer or because of various treatments to treat diseases that they have, including one that was effective as a prevention. But now the Omicron virus descendants have all mutated so that they're now resistant to those monoclonal antibody treatments and preventions. On the other hand, good news is that these Omicron variants and their descendants that are circulating around the world now have not become resistant to antiviral drugs, such as Paxlovid or Molnupiravir, or several other newer drugs that are being tested that have been recently reported since December, for example, from China, or from Japan, and elsewhere around the world. With regard to vaccines, in my opinion, the one best source of many sources for information, again, is from the World Health Organization. And the WHO OMS has a very, I think, excellent group of experts on vaccines, and they have the name Strategic Advisory Group of Experts, or SAGE, S-A-G-E, for vaccines. And at this website listed here on this slide, in the top of this slide, you can find updated advice on many international COVID vaccines, including vaccines from India, from China, from Europe, from the Americas and elsewhere. And the second reference link on this slide is a document from just 1 week ago, last week, February 20th, that this WHO Strategic Advisory Group of Experts, or SAGE, talk about the most recent so-called bivalent vaccines for COVID. Bivalent means they contain two different forms of the virus, versions of the virus, if you will. The original virus that was first found in Wuhan in the end of 2019, but also contain the most recent version of the SARS coronavirus 2, which of course is the Omicron variant. So I recommend that as a good source of information. Also, I think a very important but often underappreciated, at least in my opinion, in my country, is the what's called long COVID or post COVID-19, or various other names. But basically what it is as defined here by the World Health Organization at the website at the very bottom of this slide. And I'll just read it. It says, and I quote, long COVID is defined as the continuation or development of new symptoms 3 months after the initial SARS coronavirus 2 infection, with these symptoms lasting for at least 2 months with no other explanation, hence the term long COVID. There are many symptoms of long COVID, but the three that are listed here initially, I think are the ones that are best emphasized, and these include fatigue, shortness of breath, and cognitive dysfunction. A term that is sometimes used for the cognitive dysfunction is brain fog, which obviously is not a medical term, but we all, I think, understand what that means. But then there are many other different symptoms that can impact and interfere with everyday function associated with long COVID. We don't have a specific test for it. We don't have a specific treatment, but there are effective symptomatic treatments. The third and last bullet on this slide, or paragraph, states that, and again I quote, studies show that around 10 to 20% of people infected by SARS coronavirus 2 may go on to develop symptoms that can be diagnosed as long COVID. So obviously that's a very large number of people. In this slide, it's stated that it's believed that more than 17 million people just in the WHO European region, so one of the 6 WHO regions in the world, may have experienced long COVID in the first 2 years of the pandemic in 2020 and 2021. So that doesn't even include last year or this year. And finally, the topic that's in the news yet again the past few days, I just want to briefly address and provide what I think are just a couple of worthwhile references. So this has to do with the virus origins, the origins of SARS coronavirus 2 and the COVID pandemic. In my view, the origin clearly remains uncertain. This is a topic I've followed since the very beginning in January of 2020, including news this weekend from the United States. But in my view, we still don't know what is the origin of the virus. Did it occur naturally, related to an animal or animals that may have been infected and then infected people, and then triggered the person-to-person spread that occurred around the world? Or did it occur related in some manner to a laboratory incident somewhere, whether recognized or not, accidental or not? In my opinion, we still don't know. The world still doesn't know. I hope that the answer will be found, but as of today, I'd say we still don't know. I'd like to just close by focusing on one specific question, though, that has come out of my own search for this answer. And it doesn't have to do with any laboratories, but it really has to do with one question with regard to the Wuhan seafood market, the specific one that some people believe is the source, the animal source of the virus that then infected people working in the market and shopping in the market. So the WHO convened a global study of origins of SARS coronavirus 2, China part. That's a quote from the report, and it was a joint WHO-China study. The final report appeared on March 30th of 2021, and you can read both the report and the annex or annexes in this link that you see at the top of this slide. I've just quoted from the hundreds of pages, one statement, and that's you see on the bottom of the slide, and it's, quote, "No evidence of the sale of live mammals was found in our visit. For example, cages of the type used to house mammals like raccoon dogs." So that was stated in two places on page 122 of Annex D concerning this Hunan seafood market, and also page 98 of the main report. No evidence of the sale of live mammals was found, including raccoon dogs, which we know now can be infected with the virus, experimentally or in the wild. Mink, for example, can be infected and have been in multiple countries in Europe, particularly in the Netherlands and in Denmark, but also in the United States. Well, that report, as I mentioned, from WHO-China joint study was March 30th of 2021. And then just a couple months later, about 9 or 10 weeks later, June 7th of 2021, there was a peer-reviewed paper published in a very highly respected journal called the journal Nature, Science Reports, by researchers Hao Xiao, Newman, and others from Wuhan and elsewhere in China, from Canada, and from Oxford University in the UK. And this is a picture of the first page of the title page of the article, and it says animal sales from Wuhan wet markets immediately prior to the COVID-19 pandemic. And here they report that, in fact, there were live mammals, 18 species of live mammals, including raccoon dogs and mink, palm civets, and 15 other species that were sold at the Hunan seafood market and several other markets in Wuhan for 30 months before the beginning of the COVID pandemic. So as you can see here at the beginning of the abstract, they state that there were 38 species, of which 18 were mammals, and others were reptiles, snakes, many other species, salamanders, crocodiles, including 31 protected species sold between May of 2017 and November of 2019 in Wuhan's markets. In other words, for 30 months before the recognized beginning of the pandemic. And they note that there are no pangolins or bats traded in those markets. So the last slide, I would again just ask this one question. It focuses only on this particular seafood market and the live mammals that were sold there. It has nothing to do with laboratories. And so the question is, were live mammals, such as the raccoon dogs, the palm civets, the mink, tested for SARS coronavirus 2 in the Hunan seafood market? And if the answer is yes, if these live mammals were tested for SARS coronavirus 2, then what were the results? We know that 69 environmental samples from that market were found to be positive for the virus, but there's no information about live mammals being tested. And finally, if none of these 18 species of live mammals in this seafood market in Wuhan were tested when the market was closed at the very end of December 31st, beginning of January 1st of 2020, then then why not? Why weren't they tested? So that's the only contribution that I can offer. And it's in the form of a question having to do not with any laboratories, but with this particular seafood market in Wuhan. And so I'd like to close by saying that over the last 41 years, I've been very fortunate, as Dr. Tan said, to be able to go to outbreaks and work with international colleagues around the world and to teach about those outbreaks. There was a large exhibit in Washington, D.C. at the Smithsonian Museum of Natural History, best known for dinosaurs, but they had an exhibit on epidemics that I proposed in 2014 before going to Sierra Leone and then Liberia to work providing care for patients with Ebola. And the exhibit finally opened in 2018 until just last October in 2022. But this is a picture from the final 10th section of the 10 sections of the exhibit. And it says, where in the world are outbreaks occurring? And my answer and what I believe and what I wake up and look for every day is expressed by the statement, what's next is already here. We just haven't recognized it yet. And so we need to anticipate, recognize, and act for the epidemics that are already occurring. We need to find them, recognize them, and recognize what we need to do as a international community to slow them down, to stop them, and when possible, to prevent them from going from an outbreak to an epidemic to what I call a pan-epidemic, and then to a pandemic. So I'm going to stop sharing here, and thank you very much for your time. I think the slides will be made available by Dr. Tan, and so now I'm going to go back to our conversation.
Great, thank you so much, Dr. Lucey. If any of you have any questions about COVID, anything at all, just feel free to put it in the meeting chat. But in the meantime, I will kind of start with some of my questions that I have. So thank you so much for talking a little bit about the likely origin of the virus. So that was kind of one of my first questions. But maybe going back to your initial slides about kind of the variants, and we observe that now it's really more, it's kind of stabilizing with the Omicron. Do you have a sense of whether there might be new variants that might come up? Why are there, all these variants, different variants, and then why is it kind of suddenly stopping? Is it because the virus feels that it's adapted to the human now? We don't need to evolve anymore. Yeah, your thoughts, please.
So these are the crucial questions, and honestly, I don't think anyone knows the answers for sure. And I think people, including myself, at sometimes in years past in the pandemic, have made some predictions or said, well, this is very likely to happen, and been proven wrong by this virus. It surprised many people. In fact, I would say most people, including with the appearance of Omicron. All of a sudden, that virus has many mutations that are different than the variants like Delta or Alpha, Beta, Gamma that came before Omicron. So very big surprise. And the fact that it's continued, Omicron has continued to have so many ongoing mutations and what they call recombinations of two different versions of it is again a surprise to many people. So we don't know is the honest answer. And so I think for me, I keep an open mind and say, well, Omicron surprised everyone in the world, everywhere with its appearance and its many mutations. So could we be surprised like that again and have the next Greek letter, I think it's Rho, or no, pi or Rho or sigma, designated by WHO as the next variant of concern? Yes, but certainly we hope that doesn't happen, because it would mean that virus would be extremely transmissible, something that could spread faster than Omicron. It would really be terrible. And then if it was any more deadly, or even as deadly as Omicron, if it could spread more quickly than Omicron, that again would be a very bad situation for the world. And as far as does the virus has it well, I'll just say that I don't think like the virus, and I don't know how the virus thinks. So I think it's better just to say We don't know what's going to happen, but we need to stay vigilant. We need to continue to sequence viruses, especially if there's any appearance of more serious illness anywhere in the world. That happened with the Delta variant. That was first recognized in India. It doesn't mean it started there, but it was first recognized there. So we need to remain vigilant because the future is uncertain.
Great, thank you so much. I mean, another thought that I had was whether or not, as people are trying to live with the virus, that, surveillance goes down as well. And so there could be less intentional surveillance and, sequencing, genetic sequencing as well. Does that perhaps contribute to why, we maybe are seeing less of the variants? However, I mean, as you noted that, wherever there is large-scale mortality or morbidity, I assume that, WHO would get on there and try to get samples and sequence and see what's going on. So I guess that's kind of our marker as well.
Yes, I agree with you. And I think, WHO, but also each individual country would be very concerned if they had, more serious outbreaks in terms of hospitalizations or deaths due to this virus. So the sequencing would be hopefully done very, very quickly. And I think one of the good things that's, I wouldn't say come out of the pandemic, but has occurred, during the pandemic is much better capacity to do sequencing and other sort of state-of-the-art research, virology and immunology and epidemiology research in many more places in the world than before 2019. Just for example, in South Africa, there's a really superb state-of-the-art, world's best, no place is better sequencing and integrated immunology, virology and epidemiology coming out of South Africa. And in fact, they recognize the beta and the Omicron variants of concern first in the world. Again, doesn't mean that that those variants started in South Africa, but it means they have superb scientists who are doing this kind of research. So they're much more likely to recognize, new variants of concern.
Mm-hmm. Great. Another question I had related to what you talked about, like long COVID. So I just wanted to kind of understand, how much of the long COVID, I mean, in terms of the evidence that it is a real phenomenon versus kind of, people just wanting to, feel sick for a long time, not go back to work, for example, things like that. But, it sounds like there's a lot of reports and a lot of scientific work around this, and that it is indeed kind of evidence-based. Is that correct?
Yes, that's correct. The main difficulty, I think, is that we don't have any specific diagnostic test. And so you can get lots of criticisms about, well, it's a syndrome, it's behavioral, it's brain fog, it's fatigue, things that are not as specific as a virology PCR test for a virus. So so we don't even know if long COVID is due to ongoing virus, SARS-CoV-2 virus present somewhere in the body or not. And again, I think it's really a spectrum. The long COVID is a spectrum of symptoms of the illness and also of people who have the illness. But in my view, I'm quite old, so I've seen and heard of similar syndromes associated with other viruses or illnesses. For example, in the 1980s, I was doing my training in medicine and infectious disease, and and then there was a term called chronic fatigue, which was associated with a virus called Epstein-Barr virus, or EBV. But then it was, I think, clear that it wasn't either only due to Epstein-Barr virus or even that it was primarily due to Epstein-Barr virus. And it was similar questions of well, is there active Epstein-Barr virus replicating that could cause chronic fatigue? And again, this was in the 1980s. And then there's been other terms in other illnesses. There was something called Gulf War syndrome. There was something called myalgia encephalitis that is a reality that is been reported to have similarities and overlap, if you will, in the symptoms with long COVID. So I think it's definitely real, long COVID. I think it's some type of interaction between the initial virus infection and the initial and then ongoing immune response that for whatever reason is not able to both fight the virus and get rid of it, and also then return to the normal immune system. So I think that there's some kind of an interaction between the virus and the immune system that then becomes ongoing. And for some people that's months, for some people it's years. But I think it's real, and I think it would be terrible not to think that it's real, and for researchers not to be funded and to continue to pursue very strongly the diagnostic tests and to understand what we call the cause or the pathogenesis of long COVID, for the main reason that then we can hopefully come up with treatments, whether it's antiviral, if in fact there's SARS coronavirus 2 virus, or maybe SARS coronavirus 2 triggers some other virus. Some people have said, well, maybe it triggers Epstein-Barr virus reactivation or some other virus. But for me as a clinical physician, most of my life, I really try to focus most on how can we treat or help prevent illness in our patients. So for me, that should be the main motivating goal of studying and solving the mystery of long COVID so that we can better treat our patients.
Great, thank you. Talking about immunity, maybe we can talk a little bit about vaccinations and given that this audience is non-medical, but of course we have also physicians online, but it's really was targeted for the kind of the lay audience among our UN staff. I just wanted to seek your view on, that there are all these different types of vaccines out there, and having, recommendations for booster shots. At the same time, we recognize that, the immunity is not that long for some of these vaccines, right? So how long do people have to keep getting like booster shots, and will there be a universal vaccine that might come out in the future?
Yes. So to address your last question, that is sort of the great hope that there'll be a universal coronavirus vaccine. In fact, you probably remember when you first asked me to speak, January 14th of 2020, so just 2 weeks into the pandemic, one of the slides that I showed, I talked about SARS and about MERS coronavirus, and then about this new coronavirus that had only been reported about 4 days earlier in Wuhan, and then in Thailand the day before the meeting. And one of my slides, I talked about the hope and the need for a universal coronavirus vaccine. Just like there's a hope and a need, and there has been for many years, for a universal influenza vaccine. So it's clear that's what's needed, but it's not clear how to get there. And maybe some new technological breakthrough like the messenger RNA or mRNA vaccine technology will get us closer. But as of today, it hasn't, but it's still early. So yes, we need universal coronavirus vaccine. You're certainly right that the immune response, both to the natural infection with the virus, but also to vaccination, doesn't last for years, and it lasts varying amounts depending on the person and the vaccine and the virus. So really those three things: the person, the vaccine, and the virus. So the person, I say because it can depend on your age. So if you're over 65, like I am, then your immune system just isn't as strong as it was when you're 25 or 35 or 45. Then the virus, it can it can cause a better or a weaker immune response, again, depending on which one of the variants of concern it is. But in general, coronaviruses don't cause a very strong and long-lasting immune response after the infection itself. And unfortunately, that's the case in one specific way, but not in another specific way for the vaccine. So the two ways are, as I see it, and I should just add, I've gotten 5 vaccinations. And also I got Omicron, including the bivalent, the most recent vaccination. And I also got the Omicron infection when I was living here in New York City when it first came out in January of 2021. So, so I've gotten the vaccines because I believe they're safe and effective. And so the two ways that I see to think of to emphasize the issue about COVID vaccines, one is, does it prevent serious disease, hospitalization or death? And the answer is yes. And that's true for vaccines from China, just like vaccines from Europe or the Americas or elsewhere, and vaccines from India as well. And that protection can last a long time. We don't know how long, because they've only been available for less than many years. I'll just say a couple of years. But where, unfortunately and disappointingly, the vaccines haven't been nearly as effective as we wanted was in preventing transmission itself. And in that sense, the protection isn't long lasting. You can still get infected, even though you've had vaccinations, but you're less likely to have severe disease, much less likely to die if you've had vaccinations. So, for example, I had 3 vaccinations before the time I got Omicron. These are mRNA vaccines that are, the ones mostly used here in the United States. So, I think we have a long way to go for developing and making available in an equitable manner, especially around the world, COVID vaccines that not only protect against severe disease and death, but against transmission. And that's where we are. That's where we are today, in end of February of 2023.
So one question that I see that kind of related is like, what is the maximum and minimum duration of the COVID vaccine immunity conferred? Do we know? We're talking about 3 to 6 months. I've seen kind of WHO, I mean, it depends, of course, on the vaccine as well.
Yes, that's exactly right. It's really a range. And again, I would think of a sort of a triangle, if you will. It depends on the person's immune system, which can depend on their immune status, their age, et cetera, but also on the virus, which variant is it? Yeah, and then the vaccine, which vaccines. I mean, some are stronger than others. So it's really on that triangle or triad of factors. But even given that, I'd say the range of months. It's not in weeks, but it's not in years either, the immune protection of vaccines. And so just as an example, in the United States, there's discussion about maybe there'll have to be a yearly COVID vaccine, like the US recommends yearly influenza vaccine. But already there's, I think, a lot of appropriate discussion about that in terms of, well, is it for people of all ages or just people of, above the age of, let's say, 50, for example, or 60? So again, I think we don't know for sure. And this kind of ongoing discussion and back and forth, which hopefully doesn't degenerate into, too much emotion and anger, because that's not helpful. But hopefully, with the WHO Strategic Advisory Group of experts on vaccines, the SAGE group, there'll be continued, expert advice for the world from WHO on vaccines, who needs to continue to get boosters and what boosters and/or new vaccines. Because I think that there will be, if not in 2023, then in 2024, I think there will be new COVID vaccines, either new technology or perhaps new updated variants. Quite a few people ask now, well, is it really necessary or helpful to use the original 2019 version of the virus that was first found in Wuhan for vaccines in 2023 or 2024? So there will be evolving information and newer COVID vaccines certainly in the years to come, and perhaps even later this year.
Okay, great. Thank you. I'm going to just ask one final question before I head over to the chat stream.
Yes.
But this is something that I'm kind of curious on what your take is. So, as you know, the world has been preparing for an influenza pandemic, but, it's a coronavirus. So, should we be thinking that there would be still an antigenic shift in the influenza strains, and there still could be another influenza pandemic that would come in? And why was it that this came out of left field, that we're dealing with coronavirus rather than influenza?
Yes. So, my last slide from the museum, I said, what's next is already here. We just haven't recognized it. So we need to anticipate, recognize, and act. So I would say that nature doesn't owe, human beings anything. In other words, I think that there will be more influenza pandemics. I, of course, don't know when. The last one in 2009-10, which was the first one since 1968, was not nearly as severe as we thought that it was going to be, thank goodness. But also it was a different influenza virus. It was pandemic H1N1, first, as far as we know, appearing in Mexico, North America, rather than what most people in the world, including me, and WHO and really everyone that I know of, including the influenza experts, thought that it was going to be H5N1 coming out of somewhere in Asia or perhaps Egypt, where there have been a lot of patients in Egypt and Indonesia, but it wasn't. So again, it's really important to stay humble, keep an open mind, because the last pandemic of influenza wasn't that long ago, and it wasn't the virus that we thought it was going to be. It wasn't from the part of the world we thought it was going to be from. And fortunately, it wasn't nearly as deadly as we thought it was going to be. But that doesn't mean that the next pandemic of influenza, which again, maybe, due to mutations or other changes, reassortments in H5N1 again, as we just heard about over the past few days, from part of Eastern province in Eastern Cambodia, which it turns out that, as far as I can tell, there were just 2 people in one family that had the infection. But the H5N1, in a way, like SARS-CoV-2, has continued to mutate all these years. H5N1 was first found in 1996 in Guangdong in Southeast China, and then the first outbreak in people was the next year, 97, in Hong Kong, with 18 people getting infected and 6 dying. So over all these 26, 27 years, H5N1 has continued to mutate into different families, or what we call clades. And now there's a relatively new one that's spreading throughout the Americas, where there hasn't been much H5N1, although there was some about 5 years ago, but this is even more extensive. And it's infecting, H5N1 now is infecting mammals, much more so than before. And the one thing that really caught my attention about concern that there could be a pandemic of influenza related to H5N1, sometime in the near future, is that last October on a mink farm in northwest, I believe it was Spain, Galicia, Spain, there was a mink farm that an outbreak of H5N1 occurred, and it seemed that the virus was spreading between the mink, which we know is something that SARS-CoV-2 can do. But this was H5N1, and that, to my knowledge, had not happened before, this sort of mammal to mammal, mink to mink spread. So the world's really paying close attention. The WHO and Dr. Sylvie Briand, who I have the greatest respect for, it, led a WHO conference, I think it was maybe even over the weekend or a few days ago, about H5N1 and what do we know about Cambodia. So there's that, but also I would say that, and I don't mean to be discouraging here at all, but it's just my strongly held opinion that sometime in the years to come, there will be not only a pandemic of human influenza, but another coronavirus pandemic, which would be the fourth one this century. So we had SARS in 2002 and 3, which didn't quite become a pandemic, thank goodness, due to fantastic international collaboration, particularly, I would say, through the WHO leadership, the Director General at the time, Dr. Gro Harlem Brundtland from Norway, and then Dr. David Heyman, and many collaborators in China and elsewhere. SARS was stopped from becoming a pandemic. And then MERS coronavirus, of course, in the Middle East, and then since 2012, and then in South Korea in 2015, an outbreak. It's still going on, and it's in camels. And unlike chickens or birds that have been culled in the hundreds of millions of numbers, camels are not going to be culled or killed. So the MERS virus continues, including with some mutations. And then the COVID or SARS coronavirus too. So we've had 3 coronaviruses that caused pneumonia and death in humans just since 2002, 2003. So I think that unfortunately there will be more of them. And I think we really need to apply the lessons that we should have learned from the COVID pandemic that's still going on to prepare much better for what will be, I'll call the fourth novel coronavirus after SARS, MERS, and COVID. And then there's always some other possibility like a Nipah virus or some other family of viruses. So again, I think our world is changing. Our population is humans. I think we've crossed 8 billion people now. And that means we raise many, many, many more animals for our own protein consumption. And they have their own, bacteria and viruses and fungi and prions. And so there's this interactions that didn't happen, centuries or millennia ago between animal infectious diseases and humans. So I think it's the truth, it's the reality, and we have to face it and prepare much better and respond much faster and in a much more appropriate and comprehensive, sustained manner than we have in the past.
Great. Thank you so much, Dr. Lucey. I'm just going to head over to the questions. But before that, I just wanted to say that our team is revising our current risk mitigation plan with the UN medical directors. We're updating the guidance in there with the latest WHO information. I just see a question there from Dr. Seda about isolation period, quarantine period. So just to say that WHO has changed their recommendation. I think they're recommending that for cases who are symptomatic, they should be isolated for 10 days. For cases that are asymptomatic, they can be isolated for 5 days. For contacts who have exposure to cases, they should be also potentially quarantined for 5 days as well. But they say that if you take some antigen test, potentially you can shorten some of that time. So anyway, all that information will be in a risk mitigation plan. Having said all that, what I've recommended is from WHO. You will need to follow your local health authorities' guidance. I know that a lot of places probably do not even bother to isolate or quarantine, but WHO does recommend it, but you would need to, again, follow your local health authorities' guidance for that. One other question with regards to a colleague having very severe post-COVID subacute myositis of the muscle without any evidence of autoimmune systemic disease. Is that something common for long COVID?
Well, certainly the muscle or myalgia, the muscle pain, is common. The myositis, which to me means inflammation of the muscles, and that usually means a sort of a formal medical definition is that you can measure enzymes in the blood that come out of muscle. And if you have a myositis, then those muscle enzymes will be elevated. So for me, that's a very important objective laboratory confirmed finding. And it's true that there are other potential causes, whether they're autoimmune diseases or other infections, but by and large, they're unusual. So I would think that if the myositis, muscle inflammation, and leaking the enzymes out into the blood where you can measure them in a laboratory occurred after the SARS coronavirus 2 infection, COVID, then it's most likely related. But how that happens, we don't know that. But I think it's very important to also determine if what muscles are involved, and particularly if the heart muscle is involved, because sometimes the virus causes inflammation of the heart muscle, so myocarditis, which, as you know, as is well known, that can cause significant problems with ability to exercise or even to walk or to climb stairs, and can cause abnormalities in the heart tracing, the EKG. So that's something to be very careful about, to see if there's inflammation of the heart muscle as well as other muscles in the body.
Okay, great. Another question is about whether is there any side effects if people take like multiple doses of vaccine, like but I hear that you've taken 5 doses. Yeah, have there been any studies on that?
So there's been studies on 1 or 2 doses as well as 3 or more doses, and there certainly should be, because most importantly in medicine we say do no harm. Every medicine and vaccine can have some unusual side effect, or a side effect like a sore arm if you get an injection of a vaccine. But I think mostly what concern is about serious side effects. And so very rarely, for example, there can be some inflammation of the heart associated with some vaccinations, but it's extremely rare, and it's much less common than the SARS coronavirus 2 infection itself is in terms of causing inflammation of the heart. And there was 1 or 2 vaccines that came out in 2021 initially that were found to be associated with very rare but very serious blood clots, more commonly in women than in men. So again, even though that was very rare, it was potentially life-threatening, especially if the clots involved the blood vessels in the brain. So I think that, and I know I can say I used to work in vaccines, part of the Food and Drug Administration, the US FDA, back in the 1990s. And the 3 most important things the FDA taught me was safety, safety, and safety. So you're always looking for side effects, but especially the serious ones. And then you have to decide what needs to be done. Is the vaccine not recommended anymore, or only recommended for certain people, et cetera. So I'm not aware of more vaccines equals more problems. And it's certainly something I look out for, because again, getting 5 vaccinations, it's something that I'm very aware of, watching out for that possibility.
Okay, great. We have some questions related to antiviral drugs. I assume these are used for treatment, not so much for prophylactic, correct? Or are they used also for prophylactics for high-risk people?
No, but by and large, they're approved for treatment. Treatment of high risk, meaning people that are at high risk for developing severe disease, needing to be hospitalized, or at risk for dying, but not for prophylaxis. That would be a huge market, a huge need, a huge number of people if there were safe and effective and affordable antiviral drugs for prevention or prophylaxis. There was this one monoclonal antibody, which was a combination of 2 monoclonal antibodies called Evusheld, that was designed for prevention, so prophylaxis, especially for people who, for example, have a weakened immune system. They would get vaccinations, COVID vaccines, but because the immune system was so weak, they wouldn't make much of a protective or long-lasting immune response. So this particular combination monoclonal antibody was quite, very important, quite good for people who had a weak immune system and could not benefit from getting vaccinations. But unfortunately, now the Omicron descendant variants have evolved to become resistant even to that combination monoclonal antibody. But yeah, antiviral drugs are for treatment, not for prevention.
Okay, I'm just going to do a kind of rapid fire and then we'll close in 5 minutes just because I just
I'll
want
be very
to
short
some of
answers.
the questions. Yeah, so after the vaccine, is it possible to have long-term muscle ache at the injection area? I mean, it shouldn't last for too long.
It shouldn't typically, but is it possible? I'd say yes. Yes, it's definitely possible, but it's not typical. No.
Yeah. Okay. How common is post-COVID myocarditis? Is it and what are the differential diagnosis regards to that?
Yeah. So referring to this a little bit earlier, it's rare, but it can be very, very serious. Myocarditis, inflammation of the heart. It can lead to arrhythmias of the heart, which can be life-threatening. And it's something that really requires close medical attention, ideally by someone, a cardiologist, someone who's familiar with heart problems. Very, very, very significant.
Okay. Is it correct to label people as fully vaccinated when they were vaccinated like a year ago and booster? And I actually have that same exact question. I mean, I don't think so, but I think that for the lack of anything else, because governments can't, be tracking it so closely. There is no kind of other way to do this. What are your thoughts?
Yes. So I think this is a partly politically charged issue. It's come up a lot in the United States and I think around the world. Like, what's the definition of fully vaccinated? Originally, it was 2 doses, but then if it's been more than 1 year, and the second dose, of course, didn't include the Omicron, et cetera, et cetera. So I think it really depends on whoever the authorities are. I'd say I'd have to defer to them, local authorities or national authorities or WHO. But if you haven't had a vaccine and vaccination in more than a year since Omicron has been around, then I think you don't have optimal protection most likely. And that's for someone my age, not necessarily someone who's 20 years old or 30 years old.
Mm-hmm. And kind of associated question, is there any guideline of really, what types of vaccines should be given to staff and how many doses and all that? And again, I think I would have to refer people back to your local authorities. And if you don't have one, then you can kind of come to us and we will give you kind of that advice. But I think it really varies, correct?
Yes, I agree completely. And that's why I give that one reference or 2 references on one slide about vaccines and WHO, both for pretty much all of the international vaccines that WHO has recognized, regardless of what country they originate in, and then also the more recent Omicron bivalent vaccines. So that most recent guidance you'll always find on those WHO vaccine websites.
The 2 questions related to long COVID again. One is thyroiditis something that sorry, not long COVID. Could that be an effect of COVID vaccine or is long COVID? And then the other, is there any disturbance of adrenal pituitary dysfunction that we know of, endocrine dysfunction? Is that part of like long COVID? I mean, like, it's obviously like a lot of different things that can happen. Yeah.
Yes, absolutely. So for thyroiditis, to my knowledge, the best of my knowledge, and I'm not an expert in thyroiditis and COVID, but it's not at all a common side effect of either the any COVID vaccines or COVID itself, but it could be related, I would say, more likely to the virus itself. But also thyroiditis is fairly common in certain ages and demographics, if you will. So it might occur, after an infection with SARS-CoV-2 or after vaccination, but it doesn't mean it was caused by those. And then also there's multiple different kinds of thyroiditis. Some are autoimmune like Hashimoto's thyroiditis and Graves' disease, et cetera. So it really requires a better medical definition of what kind of thyroiditis it is. And then as far as the adrenal pituitary hypothalamic axis, I think that that's appropriately always considered and studied in people with so-called chronic fatigue from the 1980s, or with myalgia and encephalitis syndrome, or now with long COVID. Because particularly with the fatigue, you worry about the normal function of the adrenal gland that's controlled largely by the pituitary gland, and sometimes by the hypothalamus. So there are studies that can be done, and I would not be surprised at all if there wasn't disturbance of that adrenal pituitary hypothalamic axis in people with long COVID. And there might be treatment implications of that, so if there's very low production of the normal steroids made by the adrenal gland, then trying to figure out what could be done and why that's the case could lead to treatment and symptomatic improvement for those individual persons.
Okay, great. Thank you so much. I think we're over time, but I really appreciate your time, Dr. Lucey, to be with us. If any of you have any further questions, just feel free to email us and we can convey it to Dr. Daniel Lucey as well. But thank you so much. I think the bottom line is we continue to need to be vigilant. I mean, take a little break from COVID, but who knows what's around the corner. H5N1 seems to be having some, issues, but hopefully we don't face a new pandemic very soon. So thank you so much, Dr. Lucey. Really appreciate it.
Okay.
Thank you. All right. Bye, everybody. Thank you. And we will send the recording as well for those who have missed this time. All right. Bye. Take care.